Okay, everyone got that? Recording in progress. So for those of you who are new, and I see some new names, and you don't know me, I'm Maria Markowitz, and I'm from the Georgia Cancer Center, and I'm part of the hub team of the Teledermatology project. Dr. Doug Patton and I will be serving as co-facilitators of this session. So I ask all of you to, as much as possible, have your screen set to gallery view and have your cameras on, unless you've got bandwidth problems, because we want to see each other as we talk. I want to give a very warm welcome back to Dr. Kenza Mamouni, who's returned from maternity leave, and she's back here at the controls in the TeleECHO hub, and she's her office is 2 doors down from me, and so it's so nice to have her back. I want to welcome our teledermatology clinic healthcare providers today. So I'm going to just call out the clinics, and if you can wave, that would be nice. So we've got the East Georgia Healthcare Centers from Mount Vernon, Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, and Swainsboro, and the Phoebe Family Medicine residency program. I want to welcome everyone else, including members of the TeleDerm team here at the hub. So there is our dermatologist, Dr. Loretta Davis. I'm not sure if she's gotten in yet, Dr. Hale Rabinovitz, and Dr. Kendall Buchanan. And there may be some derm residents here and medical students. Definitely, I've seen some. And then here in the hub, handling the controls is Dr. Brenda Santiano, Dr. Kenza Mamouni, and myself. So remember to put your name and email and your clinic address, whatever, in the chat for us. And let's see, before we continue, I just want to mention about obtaining CME credit. If there's anyone who still hasn't figured things out and need help with registering for CME here at the Medical College of Georgia, contact Brenda and she'll help you. And obviously, I think everyone has successfully registered in TeleECHO because you're here. And if you weren't registered for TeleECHO, you wouldn't be here. You would be sending us emails. So let's see. Today's agenda is our introduction. Our didactic presentation will be by Dr. Joel Byrne, who is a 4th-year dermatology resident here at Augusta University. And then we will have a case presentation by Rashi Agrawal, a 3rd-year medical student. And then we'll have a discussion and we'll do a wrap up and have announcements. Oh, I didn't say what Dr. Byrne is talking about, which is cutaneous signs of internal disease. And now I can introduce Dr. Doug Patton, who will take over for a while. So Dr. Patton is the Dean of the Southwest Georgia Regional Campus of the Medical College of Georgia, down south, and he spent much of his career as a rural physician. So Doug, take it away.
Thank you very much, Rhea. It's good to be back, and we'll move through this pretty quickly. Most everyone has seen these already a few times. So this is the moving knowledge instead of people slide and the explanation of what ECHO stands for. We'll move to the next slide, please. Just a reminder that this is our effort to use distance learning approaches to help primary care providers around the state be able to increase their level of skills, but also to create connections so that they can get problems solved for their people where they are instead of having to send folks off necessarily all the time for in-person referrals. Next slide, please. So we are recording these sessions, as you've heard, and your participation is implied because you're still with us. This is not a consultation service, so let's remember not to mention PHI in any of our discussions. On the final slides and in the chat, there'll be information about getting continuing education credits. You can always put questions or concerns in the chat, or you can email them to teledermatology@augusta.edu. Next slide, please. So we do collect data from registration all the way through by participating in the TeleECHO platform. This helps us to track and keep up with who's participating and everything else, but also gives you access as a participant to archived presentations as well, and to the ability to get education credits for looking at sessions you may have missed, or to be able to go back and look at sessions over again for things that you might need a refresher on. Next slide, please. So just general Zoom etiquette, keep your microphones muted when you're not speaking. Unmute if you do need to speak. We ask that you initially try and ask your questions by typing into the chat. During the question and answer session after each presentation, we will invite you to open your mic and either speak up or raise your electronic hand. We'll try and catch up with you. Under any circumstances, where it is, just let us know that you have a question or a comment, and we try and encourage participation. When you do speak, in addition to opening your mic, make sure your camera's on. We like for you to keep your camera on all the time, but we do recognize there are bandwidth constraints in many locations, which might prevent you from doing that. Gallery view allows us to see as many people as possible all at once, so encourage the use of that. And again, you can use the chat for comments, or email Kenza K. Mamuni at augusta.edu. Next slide, please. Or is that our final? Yep, that's our final slide. So it's my pleasure now to introduce Dr. Joel Byrne, who is in his final year of residency with the dermatology program here in Augusta. And as you heard earlier, his talk today is going to be on cutaneous manifestations of systemic disease. And with that, Dr. Byrne, we thank you for joining us today, and we're going to turn it over to you.
Yeah, thanks for having me. Hopefully I can give a few good points for everybody. So today we're going to be discussing cutaneous manifestations of systemic disease, which is a very broad topic, but we'll do our best to kind of focus in on a few that are pretty high yield. So the frequency of skin involvement in systemic diseases and just in general cutaneous manifestations often prove to be helpful in establishing the correct diagnosis of several different systemic diseases. The skin signs of systemic disease can be specific for certain diseases, so things like lupus or sarcoidosis, but other times it's best described as suggestive of a systemic disease, so things like pyoderma gangrenosum or acquired ichthyosis or dry skin can be just related to other types of systemic disease, but not necessarily a specific sign. Cutaneous signs of disease, systemic disease, can serve as the initial manifestation of a systemic disorder, including even of a malignancy, but it can also appear later in the disease process. So the timing is very variable. So lupus is a very difficult topic. Today, I'd like to focus on the cutaneous aspects of lupus. I think most people aren't necessarily taught the different types of cutaneous lupus in medical school, at least I wasn't. Most are taught just about the malar rash, but the other types of cutaneous lupus are often brushed over without much discussion. Without further ado, there are three main types of cutaneous lupus. Each has its own different morphology or appearance, its own unique distribution, variable chronicity, and each can be associated with SLE in varying degrees, or systemic lupus erythematosus in varying degrees. So the first type we'll discuss is ACLE, or acute cutaneous lupus. This is the type that everyone thinks about with lupus. It's the malar rash. And this type happens to be very strongly related to systemic lupus erythematosus. So this is the classic butterfly malar rash, involves the cheeks and the nose. Often patients will give a history of it developing after sun exposure, and it classically spares the nasolabial folds. And again, this is typically observed in patients with active systemic lupus erythematosus, or SLE, but it can precede the systemic symptoms by weeks, or it can occur after the appearance of systemic symptoms. So the morphology of these lesions ranges from just simple mild erythema to intense swelling or edema. The duration can be from just a few hours to several weeks. Sometimes the lesions can be a bit more widespread, as noted on this on the extremity here. There can also be telangiectasias and papules, some of which can sometimes mimic more common conditions like seborrheic dermatitis or rosacea. So in those situations, you want to look for the presence of erosions or dyspigmentation, color changes, skin thinning, things like that, to help distinguish between the malar erythema of acute lupus, acute cutaneous lupus, versus something like seborrheic dermatitis or rosacea. And it's important to remember that this type of cutaneous lupus is very strongly related to systemic lupus. So the next type is subacute cutaneous lupus. So similar to acute lupus, acute cutaneous lupus, or ACLE, SCLE is photosensitive, but the areas of involvement and appearance of the rash are very different. Also, this type of cutaneous lupus is not nearly as strongly associated with systemic lupus as ACLE is. So here are some photos of SCLE. You can see widespread deep pink to violaceous plaques with surrounding hyperpigmentation. You can note that a lot of it's on sun-exposed areas, but not all of the affected areas are sun-exposed. And then this photo has somewhat of an annular appearance, which is common for this type of cutaneous lupus. And here are some more photos of subacute cutaneous lupus. Sometimes it can be described as psoriasiform and can mimic psoriasis, but this photo right here is a very classic picture of SCLE. And then just as an aside, this type of cutaneous lupus often can be associated with drugs. So things like hydrochlorothiazide, antifungals like terbinafine, even NSAIDs can cause SCLE. So it's important when you have patients with SCLE to obtain a good medical history. So the next type of cutaneous lupus we'll discuss is chronic cutaneous lupus. There are different types of chronic cutaneous lupus, but far and away the most common type is discoid lupus, or DLE. And this is something that we see very, very frequently. So this type of lupus is characterized by chronic inflammation and scarring. It has a different area of locations that it affects. So classically affects the head, the neck, the ears. And of all the other types of cutaneous lupus, this subtype is the least likely to be associated with SLE or systemic lupus. So a lot of these patients just have skin involvement. So these are nice photos of DLE, or a type of chronic cutaneous lupus. So you can see the atrophic pink and white plaques, and the pink areas indicate active disease. And in long-standing disease, you can get permanent hair loss or scarring alopecia. And I wanted to point out, this is a really good photo for involvement of the ear. Sometimes patients will come in with just ear involvement, and that's a classic location for DLE. These are just more photos of DLE. Sometimes it can extend out to the trunk, but most commonly it's going to be on the face, ears, head, and neck area. And so remember, this type of cutaneous lupus is characterized by chronic, long-standing inflammation that leads to scar. So squamous cell carcinoma can actually arise in these lesions. So if you have a patient that develops a growth within one of their long-standing lesions, just keep that in mind. Okay, so that's a very brief overview of a very difficult topic, but I think it's important just to be exposed to the three types of cutaneous lupus, and just know that each has varying classic locations. So think erythema, malar cheek, upper chest and back, and then face, scalp, and ears. and also that each has a different strength of association with SLE, or systemic lupus. So not all types of cutaneous lupus are strongly associated with systemic lupus or SLE. So now we'll move on to dermatomyositis. So DM, or dermatomyositis, is characterized by proximal extensor muscle myopathy with associated weakness, has a characteristic violaceous cutaneous eruption, and also has pathogenic circulating antibodies. So the dermatologic manifestations are frequently precede the onset of muscle disease, but when you do get muscle involvement, it's the proximal muscle groups. So patients may often have issues, combing their hair or standing up from a sitting position. There's a bimodal incidence, so you'll have patients that get it between the ages of 40 and 60, but also 10 to 15 years old. Okay, so the most important association with dermatomyositis is with the potential for malignancy, which occurs in up to 40% of adults. So that's a very significant number. Oh. Fortunately, though, this malignancy risk does not apply to children. And then the appearance of dermatomyositis, it can have a wide-ranging appearance. It can have a lot of overlap with other autoimmune diseases like lupus, scleroderma, Sjogren's syndrome. And then similar to lupus, it's very much a systemic disease, so it can affect the lungs, the heart, and the esophagus. So now we'll go through a few characteristic features of DM. So number one is the heliotrope rash. And so obviously you can see erythematous patches with a slight scale on the eyebrows. And one thing to note is that not all cases are this obvious, okay? Sometimes the erythema can be very, very subtle. And then in those cases, you want to really look to see the edema or the swelling in there. So you can really see the edema in this photo here. But sometimes the superficial skin change won't be there. So the next feature is the shawl sign. This is erythema involving the back of the neck and the upper back, and sometimes can be more widespread, and sometimes can have somewhat of an abraded appearance. So again, this can sometimes be difficult to distinguish from lupus. So let's compare this to lupus. Okay, so classically you'll read about dermatomyositis having more of a violaceous color, but sometimes it's hard to see. I think maybe the more important thing to remember is that dermatomyositis has the heliotrope rash, okay? Lupus doesn't have that. And also, when you're thinking about symptoms, dermatomyositis has more prominent itch compared to lupus. So the next feature is atrophic dermal papules. This is formerly known as Gottron's papules. So this is also something you can distinguish from lupus. So in dermatomyositis, as you can see here, the knuckles are involved, okay? So that's opposite of lupus. In lupus, the knuckles are classically spared, and you'll have rash between the interdigital skin. The next feature is the V sign, which is essentially just photosensitivity and erythema in photo-exposed areas. And again, sometimes this is very difficult to distinguish from lupus. In either case, these patients are going to get a full workup for many autoimmune diseases. So but keep in mind the heliotrope rash and the difference in the knuckles. And sometimes you can maybe just say that lupus has more scale on the skin compared to dermatomyositis, but it's all very difficult. So the next disease we'll discuss is scleroderma. So this is characterized by autoantibody production, collagen deposition, and vascular dysfunction. Similar to lupus and dermatomyositis, this is very much a systemic disease. It can affect the connective tissue of any organ, so the skin, GI tract, lungs, kidneys, heart, blood vessels, you name it. Pulmonary disease in these patients is the leading cause of mortality, so patients can have either ILD or PAH. And there are 3 different types. Each has different characteristics. The approach to care for the patients with scleroderma should be multidisciplinary, as with the others. For the limited and diffuse types, a dermatologist should always be involved. So for scleroderma, these are photos of sclerosis and digital infarcts. These are very characteristic of scleroderma. You can see that the shiny and taut, sort of bound down skin over the digits, and sort of maybe the beginning of a contracture. And on the right here, you can see the sclerosis and infarction was so severe that you're starting to get bone resorption there. And we've actually seen a couple patients with this level of disease. Sometimes they'll describe what's called the prayer sign, which means that patients are not able to perfectly oppose the palmar surfaces of their hands because the fibrosis is so severe. So these photos demonstrate telangiectatic mats on the palms and fingers. Also note again, the digital ulceration and bone resorption here. As the disease progresses, there's a paucity of wrinkling on the nose, and there's a reduced aperture of the mouth, and the skin thickens. And so this leads to a beaked appearance of the nose and pursed lips. And so another prominent feature of scleroderma is pigmentary changes. So classically, you'll get these deep pigmented macules and patches, but they'll have these perifollicular sparing or perifollicular retention of pigment. So it's very characteristic of scleroderma. And this gives sort of a salt and pepper appearance. And unfortunately, this is very distressing to patients. And sadly, it's not very responsive to treatment, but very characteristic feature of scleroderma. All right, so those are the three big rheum, derm, systemic diseases that I wanted to cover. Each of those has numerous cutaneous manifestations, very difficult subject, but it's important to keep an eye out for those features because those patients need to seek treatment very quickly. So moving on, we'll talk about more focused topics. So endocarditis can have a few different cutaneous manifestations. So Osler nodes are red, purple, slightly raised, tender nodules. Sometimes they can have a pale center, and they favor the finger pads or the thenar and hyperthenar eminences. So pain often precedes the development of these visible lesions by about 24 hours. And it's thought to be secondary to immune complex deposition and small vessel vasculitis. So remember that these are tender by saying ouch, ouch, Osler. That's what I was taught in medical school. So other features of endocarditis are Janeway lesions and splinter hemorrhages. So a quick note on splinter hemorrhages. So these are very, very commonly seen in trauma. Okay, so not every patient with a splinter hemorrhage is going to have systemic disease, but it can be a feature in endocarditis. And so these are Janeway lesions. So in contrast to Osler nodes, these are non-tender, and they're often hemorrhagic, which means they're kind of bleeding into the skin. So you can see they're more pink and red here. And these are thought to be septic emboli with microabscess formation. Okay, so I'm not sure how many pediatric patients make up your patient population, but there are a couple points that I wanted to make regarding hemangiomas and the potential systemic diseases or conditions, because hemangiomas are very, very common. And I think sometimes it's easy to fall into the trap of just automatically assuming, oh, hemangioma is fine, nothing to worry about. But there are a couple things that you need to keep in mind when you see hemangiomas. So we'll go through those today. So just briefly, hemangiomas are far and away the most common benign tumor of childhood, 4 to 5% of all neonates. Sometimes hemangiomas are harmless and treatment is not necessary. If you have a small one on the abdomen, no big deal. But there are some cases that absolutely need treatment. Okay, so that's when it's a threat to vital function. So think of feeding when it's near the eyes or having issues with breathing, or locations that are high risk, so the nose, the lip, the eyelid, things like that. And then anytime you have a hemangioma that ulcerates, they're at increased risk of scarring and infection. So that's an indication for treatment. So focus of this whole topic, when do you need to be concerned for a systemic process or just something else with hemangiomas? When is it not just a simple hemangioma? So the first thing is multifocal infantile hemangiomas. So this is when a kid has 5 or more hemangiomas, and this typically signals an increased risk of systemic involvement or involvement of an internal organ, most commonly the liver. So for these patients, all of them need an abdominal ultrasound. And in some cases, patients can develop hypothyroidism because the hemangiomas secrete type 3 deiodinase, which converts active T3 and T4 to reverse T3. And so you would consider thyroid studies in these patients as well, and just refer to dermatology. So, this is at first glance, you might think, oh, simple, just, a few hemangiomas. But if there are more than 5, remember, there could be a sign of other organ involvement, and they need to have a liver ultrasound and refer to derm. So the other thing that I don't think it's important for you to remember everything that's associated with these 2 syndromes, but just know that they exist. So Faces syndrome, which has its own long list of associations, coarctation of the aorta, eye abnormalities, posterior fossa, brain malformations. Again, that's not really the point, but the point is, if you have a child come to you with a large segmental hemangioma on the face like this, okay, you need to be thinking that this could be associated with a syndrome. Okay, so this could have systemic involvement. So in these patients, there can be severe brain and heart involvement, and they need a very, very thorough workup, and multiple specialties need to be involved. Okay, so again, when you see this, just think, refer to derm. They'll need to have multidisciplinary care from there. And it's important because for these patients, you can't just start propranolol, the oral therapy to treat hemangiomas, because some of these patients have coarctation of the aorta, vascular anomalies. And so in those cases, the propranolol would be contraindicated, actually. So similar thing, but just on the opposite side of the body. So lumbar, think lower body hemangiomas. So anytime you have a patient with a large segmental hemangiomas overlying the sacrum, and extending onto the buttock here, that's when you need to think that it could be related to a syndrome with a long list of other potential issues like renal abnormalities and urogenital issues as well. You can even have imperforate anus. So lots of different manifestations here. Okay, and these are more obvious, but locations of significance. You have it near the eye. It can invade the eye itself and affect vision and lead to astigmatism and just severe vision changes. And then for the beard distribution here, sometimes it can be much, much more subtle. Okay, so if you just have it, let's say that you just had the hemangioma right here and not extending all the way, this child would need to be referred to ENT to rule out any airway involvement. Okay, so these are 2 very significant areas that you need to think about whenever you have hemangiomas. So another point about hemangiomas, so not every vascular lesion in a child is a harmless hemangioma. Okay, there are numerous vascular tumors and vascular malformations. Each has its own unique associations. Some actually have potential life-threatening complications, and some can be associated with systemic syndromes. Okay, so this is called a composite-form angioendothelioma, KHE. Again, not something I think you necessarily need to remember the name of, but just know, sometimes maybe this isn't just a simple hemangioma. Okay, so here's a good contrast between the 2. Very, very bright red is like shining at him, whereas this is more subtle. It's got a lot of like dermal components, more indurated. And this is, typically present near at birth or a few days after. So this can be composite-form angioendothelioma and can actually be life-threatening due to thrombocytopenic coagulopathy. So it's just important to remember that not all vascular lesions in kids are harmless. Okay, so sort of on that note, again, sometimes if you're having a bad day, you might think, oh, this is a more obvious one, but you might think, oh, it's just a hemangioma, but this is a port wine stain. And whenever you have a patient with large involvement like this, they are at very high risk of tuberous sclerosis, which is a systemic disease with lots of different manifestations such as seizures, developmental delays, behavior problems. They can have strokes. So in these patients, derm needs to be consulted to help coordinate care, and these patients need to get an MRI. Okay, and this is just and one thing I wanted to mention is that over time, these patients are born like this, very, very flat, skin, but nodularity starts to develop with time. But this can be prevented. So this is a before and after photo of a patient with port wine stain that was treated with a laser, PDL, which we actually have this in our clinic, and we treat patients like this. So it's pretty amazing. You can prevent this outcome by treating with lasers. So another thing to keep in mind. That if you have a patient with a port wine stain, they can get treatment to prevent the formation of nodules. All right, so moving on to very, very common things that can be associated with systemic disease, acanthosis nigricans. Unfortunately, we see this all the time. There are two different types: obesity associated. This is the more common one, and it is associated. Well, there are more than two different types. So this one is the most common. This is a sign of insulin-like growth factor, insulin resistance. It's associated with diabetes, metabolic syndrome, and PCOS. And the other type is malignancy associated, so specifically gastric carcinoma, although numerous other malignancies have been identified. And so think of this in your elderly patient who is thin and suddenly develops new acanthosis nigricans. That should sort of ring the alarm in your head, okay? And typically acanthosis nigricans is going to be located on the neck or skin folds, whereas that's for the obesity-related one. The malignancy-related one are more atypical areas, so maybe extensor surfaces or the hands, even in the mouth, okay? So there's some photos of acanthosis nigricans. This is the obesity-related type, and you can see oftentimes we'll also have skin tags there. So for these patients, we always tell them, please go see your PCP. Get up to date screening with lipids and high blood pressure, all that, and we encourage them to lose weight as well. And so this is just more photos of acanthosis nigricans. This is in the axillae. And this is the malignancy-associated type. So you can see just atypical location, okay, on the hands here. So this is actually from a patient who had cancer. Both of these are actually. So just remember, if it's not in a typical area and not in a typical patient who's overweight, think that this could be related to a malignancy, okay? This photo here is from a patient who had squamous cell carcinoma of the lung, actually. So, and other name for this is called tripe palms. So another pearl there. All right, so this is a controversial topic, the sign of Lesser Trelot. This demonstrates the rapid appearance of multiple SKs or separated keratoses. And it's debated on whether or not if it's truly associated with malignancy. I think the issue is that we see patients with so many SKs all the time that sometimes it's hard to discern when you're getting the rapid appearance of these new ones, or if they've been there forever and finally they're noticing it, okay? Because it's hard to see your back. But I think maybe something that could be more specific sign that this could be related to cancer is that if it appears rapidly and if they're inflamed or irritated, okay? So, and these patients can have a concurrent acanthosis nigricans. So in these patients, you may want to have a higher index of suspicion for cancer. So these are photos of SKs. We see this in clinic all the time. And again, SKs, sometimes they can be very, very large. They can look 1,000 different ways. This is from a patient with skin of color. These are essentially SKs, but they have a fancy name, DPN, dermatosis papulosa nigra, but they're the same thing, but just on the face. Okay, so psoriasis. Obviously, psoriasis is very common, but I think sometimes we may drop the ball in remembering how strongly psoriasis is associated with cardiovascular risk, cardiovascular disease. These patients are very, very high risk compared to the average patient. Okay, so all of these patients should be up to date with age-appropriate screening, and make sure that they're aware that they have a higher risk of cardiovascular disease than the average patient. And there's some debate on whether or not patients with psoriasis have an increased risk of lymphoma as well. So this is something that we see very, very commonly as well. So you can see these lines here, those are healing excoriations. And see how these are kind of angulated. This is kind of like a giveaway that this patient's been really scratching. And this is an excoriation right here of a papule, another excoriation. So this is a patient who had ESRD. You can see fistula there. And these patients just unfortunately are oftentimes very itchy, and they can have hyperkeratotic papules like this, or they can just have very, very dry skin. Okay, so this is very, very common in patients with CKD or ESRD. So with cirrhosis, you'll have findings like spider angiomas and also palmar erythema. And then moving on with to nail findings in both cirrhosis and kidney disease. Sometimes these can be very, very similar and it's hard to distinguish, but Terry's nails are supposed to be involving all but the distal aspect of the finger, whereas Lindsay's nails are supposed to be half and half, so it involves just half of the nail. But in any rate, whenever you see color changes like this in the nail, it should be a sign for you to think, oh, this patient might have something else going on internally, okay? Because sometimes this can be the first manifestation of disease. Okay, and then lastly, so pyoderma gangrenosum. This is something that we see actually very commonly. And I think some people may not fully appreciate how common this is to be associated with systemic diseases. So in about 50% of cases, this is associated with a systemic disease. So things like ulcerative colitis, inflammatory bowel disease, myeloma, leukemia, many other conditions. And so these patients really, really need a thorough workup, okay? And, so refer to derm and just remember that anytime you go, these lesions should not have debridement because if you debride these lesions, it will get worse, okay? That's pathogy. Just remember, if you're having a leg ulcer in a patient that's not healing or getting worse, always think about pyoderma gangrenosum, and then that there's a strong association with several different systemic diseases. So, all right, that's it. So hopefully everybody learned a couple things there. So it's carnival season in Louisiana, Mardi Gras next week, and so I always like to include some photos or something that's related to me. So if you haven't been, I definitely recommend going to New Orleans in the winter or spring, but don't go in the summer, way too hot.
Oh, come on, Dr. Byrne. It's the best place to be when it's 100 degrees and 98% humidity. Thank you so much for that presentation. We're going to just ask if you have questions now to put those in the chat. We need to make sure we leave plenty of time for the student presentation. But please do put your questions or comments in the chat. We'll come back. Dr. Byrne, thank you very much. It's a very comprehensive review of some complex material there. But it's my pleasure now to introduce Rashi Agrawal, who is in the middle of her 3rd year of medical school, but she's actually done with her clerkships, and she's in this phase we now refer to as enrichment, which is kind of an extended 4th year. So Rashi, let's go ahead and proceed with your case presentation. Again, if you have questions for Dr. Byrne or comments, please put those in the chat and we'll come back to them when we're done. Rashi?
All right. Can everyone see my screen okay?
We can. Thank you.
All right, perfect. So thank you for that lovely introduction, Dr. Patton, and thank you, Dr. Byrne, for your presentation. So kind of keeping in line with the idea of cutaneous signs of internal diseases, our patient is going to kind of touch on those topics a little bit more. And I worked on this presentation with the help of Dr. Buchanan. So just an initial thank you to her. So our patient, he was a 52-year-old Caucasian male, multiple medical comorbidities. He had chronic kidney disease, type 2 diabetes, hypertension, and other medical comorbidities that weren't fully controlled. And so he came to dermatology with a diffuse red itchy rash. It didn't have any scale in it, had central clearing, and he had been seen multiple times previously and had been diagnosed with a systemic fungal infection and was given oral antifungals multiple times. So when he came in, these are kind of his pictures we took of when he first presented. So as you can see on his arms, he had multiple red annular, so circular plaques with a central clearing, raised borders. It's important to note that there is no scale on his lesions, and then on his back, he had diffuse pink-red papules all along his back as well. And so further look into his pictures, because that one was kind of far away. So as you can see, he had those circular pink plaques. They had central clearing, kind of less pigmented in the middle, had the raised red border around, and no scale. I'm going to keep on saying no scale, and you'll keep on hearing me say that because it's a very important part of this patient's presentation. And so to start off, we came up with the differential diagnosis for annular lesions, so kind of circular lesions. Now that's a very broad differential, and so we narrowed it down into two categories, non-scaly and scaly, and kind of the more common conditions you would see under those blanket categories. So first, on our left are some pictures of granuloma annular. So there's two versions of that. There's localized and there's diffuse. In localized, you see kind of the red plaques with the central clearing, no scale. The center is often a little bit depressed, and in diffuse GA, you'll have those same annular plaques, but you might also have widespread skin colored or pinkish purplish patches and small papules as well. And they'll often be found on the trunk. They can be found in the skin folds like armpits and groin, and patients will also complain of itch. Sarcoidosis, as seen in these pictures here, also annular lesions, so circular lesions. They're going to be thick. They can be plaques, they can be papules, they can be nodules. So kind of have a more like deeper dermal involvement, and they can range from all different colors, purple, red, they can be brown, they can be pink, and patients can often present with associated other symptoms like fever, fatigue, sweats, and then about 30% of people with cutaneous sarcoidosis won't have systemic lesions, but it's important to note that if you do have patients coming in with these kind of annular lesions, they're complaining of lung issues, of shortness of breath, of coughing up blood, hemoptysis, or kind of heart issues, or eye itch like uveitis, then think of sarcoidosis. Next on the left is necrobiosis lipoidica diabeticorum. So kind of in the name, it's a very rare skin condition, but it's seen in diabetic patients. It's most commonly found in the calves. It's going to usually be an ovoid or a circular shape. An important characteristic of it is that you're going to have kind of central epidermal atrophy. So in the picture, kind of in the top picture, you can kind of see that it almost looks like the top layer of skin is thinned out and you're seeing below the surface of the skin, which is kind of characteristic for necrobiosis. And then tinea corporis. So now we're kind of starting our scaly differential. So tinea, it's going to be a circular red patch or plaque. It's going to have a raised leading edge, and it's going to have scale. The scale is usually going to be around the outside. There's going to be central hypopigmentation, but it is important to note that there is tinea incognito, so that it might have the same shape. So the circular red annular plaque with like a leading edge, but with no scale. So it's important to have a good history of your patient as well. And final two, so subacute cutaneous lupus erythematous, that also will show up with annular plaques, sometimes scaly. The plaques can kind of coalesce to form polycyclic patterns. It shows up in sun-exposed distribution. And as Dr. Byrne had kind of talked about earlier, subacute cutaneous lupus has a moderate association with systemic lupus. And finally, just wanted to talk about plaque psoriasis. So that's going to be your red scaly plaques. It's often described as a salmon-colored plaque with like mica scale, but it's important to note, as you can see in this picture, for skin of color patients, for those with darker darker Fitzpatrick skin types that it might not be that pink patch that it's also often described as. It might just be hyperpigmented and brown or darker. And so kind of going through our differential, but back to our case. So kind of key features from our patient. He had the annular pink plaques. He had central clearing. There was depressed in the inside, and he didn't have any scale, and the borders were slightly raised. And on his back, he had diffuse small pink granulomatous papules. Other stuff, he had already tried antifungal treatment because the leading diagnosis before had been disseminated tinea corporis. None of those antifungal treatments had helped, and he had multiple medical comorbidities. So our diagnosis for this patient was granuloma annulare. I did want to touch on a couple of things really quickly. So we kind of talked about this patient, his leading diagnosis before he came into dermatology and was given the diagnosis of GA was that he has systemic tinea. A patient, if he did have disseminated or systemic tinea, then that would warrant further investigation. You might want to do age-appropriate screening for causes of immunosuppression. If they're a high-risk patient for HIV, do screening for HIV. And if you're going to have a patient put on systemic or extensive oral antifungals without confirming a diagnosis of a fungal infection, then it's important to note that there's a lot of serious side effects, such as hepatitis with a lot of the azole medications. So back to our case, so GA, there's no really pathognomonic morphology seen in dermoscopy for GA. The vessels, they're very nonspecific. They're blurry, they're variable, they can be dotted, linear, irregular, branching, or arborizing. Often the lesion will have a pink to red background, but important to note, once again, in dermoscopy, you won't see scale in GA. And just in, if you do a biopsy and you get the H&E report back, you'll see that there's granulomatous inflammation. It mostly occurs in the superficial to mid dermis. GA is usually diagnosed clinically because it has a very characteristic appearance. But if the diagnosis is not obvious or there's other conditions on your differential as well, skin biopsy can be really helpful in kind of confirming that diagnosis. And so I kind of had described GA before, but kind of key features of it is that it's often in an annular pattern, it lacks scale. The localized form is more commonly found in children. It might be on their joints, the dorsal surfaces of their hands, might show up on their ankles or their dorsal surfaces of the feet. And in adults, generally, it'll have the diffuse generalized form. They'll have the classic pattern in certain locations, but they'll also have diffuse small papules as well. And for the diffuse generalized form, there is no cause for GA, but it has been found, more commonly found in patients with diabetes mellitus, dyslipidemia, certain infections like varicella zoster, TB, malignancy, certain drugs like amlodipine or TNF-alpha inhibitors have also been found in association with GA. So it's important to get a good history taking. For treatment for GA, there's really no treatment, no end-all treatment. Sometimes the lesions will self-resolve, and you really only pursue treatment options based on the patient. If the patient has complaints of itch, or they don't like the appearance, or they don't know when it'll self-resolve, you can do, for localized GA, you can do topical corticosteroid therapy with high potency like clobetasol. You can do intralesional Kenalog injections. It's important to note that steroid-induced hypopigmentation can occur in patients with darker pigmentation. And then for generalized GA, I have a bunch of options written. There is really no efficacy data for systemic treatment for GA, and they're very limited and insufficient. So you kind of have to do shared decision-making with the patient and see if they want to pursue systemic therapy, because they can have a lot of adverse effects as well. In our specific patient, we just did topical triamcinolone as needed. His main concern was the itch, not really appearance. He just needed something to help with the itch. So topical triamcinolone had helped with that. Just the clinical pearls that I think this presentation I really wanted to focus on. The main kind of conflicting diagnosis with GA would be tinea corporis, because of that central clearing is very similar, but it's important to note that tinea corporis will have scale. Now the scale won't always be readily visible, and so doing like a potassium hydroxide prep will be really important in kind of making that diagnosis. I talked about tinea incognito, that might not have scale, and so it's important to ask a patient, have they done anything at home? Have they seen any other providers for the rash? And asking if they've done any topical steroids. And so if you can't do a potassium hydroxide prep, then referring them to dermatology or sending a sample off of the scale for a fungal culture can also work. And so if you do think it's tinea, avoid combination medication that combines steroids and antifungals. Steroids can aggravate fungal infection. So if you're gonna prescribe something for tinea, just do an topical antifungal, and anything that scales, please scrape it. All right, thank you. And then just some overall questions, kind of asking for the dermatologist, seeing what they've seen in practice and tying in Dr. Byrne's presentation for earlier. If you have any thoughts about what the most common comorbidities in association with GA, and if you've seen any treatment options that help diffuse GA. Thank you. Once again, thank you, Dr. Buchanan, for your help in putting together this presentation.
Thank you, Rashi. It was a great presentation, very comprehensive. And again, follows on nicely to Dr. Byrne's presentation, just chock full of information. I don't see any questions in the chat, although Brenda mentioned something about the lesion on the arm could be easily confused with larva migrans. Cutaneous larva migrans are what we used to refer to in Florida as the Cuban itch. That's true about a lot of these things. We're running close on time. Any comments from any of our dermatologists who are on about this? I don't see any questions right now.
I was just going to say, localized form in kids often occur in areas of trauma. They usually go away on their own, so you hate to traumatize a child by giving intralesional steroids. Sometimes you're treating the parent instead of the child, because those do go away without any scarring. And in adults who have the generalized form, many of them don't have anything underlying that we would treat as dermatologists, but diabetes would be the thing that you would be most concerned about. And we have a huge toolbox in dermatology, and none of those things predictably work with generalized GA. So it's definitely try one thing and then try another thing. It's really bothering the patient. And many times it is very much a cosmetic concern, as you can imagine.
That's great. Thank you. Dr. Buchanan, thank you so much again for your assistance with helping Rashi put this together. Any comments?
You're very welcome. I will just add that it's not always obvious to see the scale when you're considering tinea in your diagnosis. I've been fooled so many times. So really, sometimes you just take a small blade and you can reveal a very fine scale that can sort of help you make that diagnosis. And then in terms of GA, we also do want to ask patients about smoking. In a lot of the studies with GA, patients who were diagnosed with that were more likely to have smoked than patients who didn't have it. So just a few other things to keep in mind.
Thank you very much. Before I turn this back over to Dr. Markowitz, I'm just assimilating some pieces here and recognizing how complex this could be. And when we're trying to focus on something that appears to be a skin problem, but obviously could have much more significant implications, being able to get the expert advice and a consultation from a dermatologist doesn't necessarily mean you have to send the patient. We can start with a good history, number one, particularly about all these things about their health, their medications, and things like that. A description, how to describe the lesion, so we get comfortable with the lingo that the dermatologists are using. Not hard, just need to get used to it. And then there seems to be value in capturing some regular photos in addition to using the dermatoscope to be able to kind of create that complete picture. And I don't know if any of the dermatologists would weigh in on that, but I still think this is an opportunity for us to help the primary care providers in their location make decisions about what to do next for these patients. Any thoughts before we turn it over?
Yeah, absolutely. I think clinical pictures are so important. For example, even with the case with granuloma annulare, when you look at it, it was a smooth surface. A smooth surface tells you that it's not epidermal component, it's a dermal component. That is the actions in the dermis. And when you see that pattern, it's classic for what's called a granulomatous dermatitis, which is either granuloma annulare or sarcoid or necrobiosis lipoidica. So by taking a good clinical picture, you can make a diagnosis 80% of the time, particularly for the inflammatory diseases.
That's great. So we know that we can still get the help of the dermatologist again while the patients are there in our offices. All right. Well, with that, I wanted to thank the two presenters again and then turn it back over to Dr. Markowitz to close us out.
Okay, well, thank you, thank you both, Rashi and Dr. Byrne, for great presentations today. The next session is March 4th with Dr. Rabinovitz speaking on the aging population, normal versus abnormal. Some of us are a little more in their senior years here, so that's rather important. And then the case presentation will be by Rushan Momin. The CME code is on this slide and also in the chat. And if you have questions about the CME, contact either the TeleDermatology at augusta.edu or Brenda Santiano or at whatever's in the chat, Brenda's email address. And a reminder to our clinics who participate in teledermatology to keep sending in your consults to Dr. Buchanan. And thank you all for attending, and all the guests can leave now. And
I have one quick thing. I realized my PowerPoint, I've put tuberous sclerosis instead of Sturge Weber. So I corrected that. I had it correct in the comments. I don't know if everyone gets a copy of the slides, but
It will be archived for sure. Thanks for
Okay.
picking up on that.
well, I can upload an updated copy of it.
That'd be great.
That'd be great.
And this is Dr. Byrne. Go Tigers.
Okay,
Yeah.
and Dr. Buchanan is sending a note to our TeleDerm clinics to use, it just disappeared, to use alcohol, what are you saying? Use alcohol when taking your dermoscopy photos. I can't see through the scale. So that message, so all the guests can leave, and the TeleDerm hub people, if you can stay on just for a couple minutes. I know we're running late, but thank you very much.